So the next session is Why Wellness Matters, and we have an outstanding panel here. I'm just going to speak loudly so I don't stand in front of the panel. And so this panel is going to be led by Dr. Dave Liu, who Brian was talking about recruitment, and I'm so talented that I recruited him twice.
Oh, nice.
He left, he came back. But Dave is absolutely outstanding. He's an associate professor in our department of emergency medicine at the University of Washington. He actually chairs our committee for wellness and what we're calling wellness and faculty fulfillment, and he'll talk to you a little bit more about why we take that approach, I'm sure. But he has a real expertise. He's also the associate medical director for quality improvement for one of our hospital sites, and he has a real expertise in wellness and burnout and its impact on quality and safety, and faculty satisfaction. He completed his training at Northwestern in emergency medicine, then came out to UW, then left, then came back, and we're going to keep him forever now because we love him and we hope he loves us. I also want to introduce the rest of the panel. Andra Blomkins. Andra is the chair at Stanford University. She is a national leader and an innovation advocate who promotes that the best patient-centered programs depend on clinical practice innovation, continuous data-driven improvement, and interdisciplinary collaboration, and is...
And that's enough. That's good. That's good.
She's certainly making inroads in all of that. Prior to going to the Stanford, she was at UT Southwestern and got her MBA specializing in innovation and entrepreneurship there. Dr. Richard Hamilton, down there, professor and chair of emergency medicine at Drexel University College of Medicine, is also the regional associate dean for the Crozer Keystone Campus and emergency medicine system chair of the Crozer Keystone Health System, so has an incredibly broad view of emergency medicine, particularly in eastern Pennsylvania, but he's a graduate of Penn and the Hahnemann University College of Medicine, trained at San Diego Naval Hospital and the Naval Aerospace Medical Institute, and completed his EM residency at the Bronx Municipal Hospital Center in Albert Einstein. Also did a toxicology fellowship. He's amazing. He's received numerous awards for his teaching, his research. He's published widely, and it goes on and on. And then Dr. Steve Bird, who is the vice chair for education and the residency director for emergency medicine at the Department of Emergency Medicine at the University of Massachusetts, also a toxicologist, and the recipient of some funding for novel neuromuscular protection to counteract organophosphate poisoning, and as well as a UO1 for pharmacotherapy to counteract parathon-induced NMJ dysfunction. His interests are medical education, metacognition, toxicology, and organophosphorus pesticides. So I want to thank you all, and this should be a great session.
Thank you, Sue, for that awesome introduction. So again, my name is Dave Liu. I'm faculty at the University of Washington, and I want to thank all our panelists for saying yes, especially Steve Bird at the very, very last minute. So thank you all again for joining our panel. So wellness has been a trending topic, obviously, over the last decade, especially during the COVID pandemic. It's been on the forefront of everybody's minds. I'm sure you've all heard some iteration of a wellness talk that kind of talks about all the causes of burnout and strategic, interventions that, maybe address it. This talk isn't that. That's beyond the scope of what we have time for. This talk is really focused for chairs, vice chairs, residency program directors, leaders in your department, and the goal is to focus on why wellness should be a strategic goal from an educational quality standpoint, and also from a financial and business standpoint. So no disclosures. So again, just to briefly remind everybody, we have Andra, Rich, and Steve as our distinguished panel of panelists. So just a brief outline of what we're going to do today. We're going to just spend 10 minutes briefly on why wellness matters to department leaders. We're going to spend some time where the panelists talk about what they do with wellness at each of their shops. And then we're going to spend a little bit of time looking at some highlights from recently published SAEM data from the faculty survey. And then we'll spend the majority of time on our Q&A with our panelists. So the big picture statistic here is that you're all probably aware about 45 to 65% of EM physicians at any one point report burnout. So this is the latest data from the Taste-Shanavelt group, where they do a national study of physicians from all specialties looking at burnout. The blue is the average, and as you see at the very, very top, emergency medicine traditionally, historically, has always been the most burnt out specialty compared to other specialties. So the dark bar, 2020, is the most recent data, and we're still number 1. There are lots and lots of reasons why EM is probably the most burnt out specialty compared to others. This isn't the forum to talk about that, but the important thing to notice is that at any one point in your department, about half of your faculty and residents are experiencing burnout, and it's an important strategic goal to address it because half of your population is going to report burnout. So there are lots of reasons why you should care. So the first and probably the most important one is there's a personal case for investing in wellness. So we know from research that burnout affects people's health. So it increases the risk of cardiovascular disease, hyperlipidemia, and diabetes. And the theory is that it's because studies have shown that burnout increases your risk of having higher levels of cortisol and other stress hormones. We also know from research that burnout increases your rate of occupational injuries. So this has been traditionally studied from the point of needle stick injuries, and they've shown that people who are burnt out experience higher rates of those. But during the COVID pandemic, this hasn't been studied or published, but I'm sure if someone were to study it, we probably would see that people who are burnt out probably are more lax with their PPE, I imagine. And the reason I say that is because I personally get more lax with my PPE and donning and doffing when I'm burnt out. So if someone were to look at this, I bet they would also find that potentially burnout is associated with higher workplace COVID transmissions. Research also shows that burnout increases likelihood of alcohol and drug use, depression, and suicidal ideation. There's also a compelling educational case for why we should invest in burnout. So we know from a study of internal medicine residents that residents with burnout actually scored significantly lower on their in-training service exam compared to residents who were not. And the difference was actually quite impressive. They found that the difference was, I think, 4 to 6 points on the ITE exam, and that's a difference of a year. So people who were burnt out PGY3s were scoring at the same as a PGY2, and the PGY2 was burnt out was scoring at the level of a PGY1. And the theory was that because burnout causes residents to have low motivation to read, study, and be engaged in their education. But in addition to that, we also know that from research that burnout decreases the teaching of residents and medical students. So my group, we did a qualitative study a couple of years ago where we interviewed a bunch of senior residents from 4 different academic sites, and we asked them about burnout. And one of the things that came up over and over again was that senior residents who were part of the study said, when I'm burnt out, I am much less likely to teach my junior residents and medical students about what's going on. This person has a lactate of 4, has a peritoneal belly. I don't explain it. I just say, call the surgery resident and take them to the OR. Like, I just don't have the energy to explain that to them. These senior residents also pointed out that faculty also have lower motivation to teach when they are burnt out. It's much easier to say, you know what, we're not gonna spend this time teaching the junior resident how to do this really complex reduction. It's easier to just call ortho and have them do it, or you do it as a senior resident because we're so busy. We just don't have time with the bandwidth to do it. So that's what we notice with education. So there's a compelling educational case for addressing burnout for your learners. There's also a compelling quality case for investing in burnout. So lots and lots of research have shown that it decreases productivity. Physicians are less efficient. They generate less RVUs. There's also more research of resource use. So physicians who are burnt out tend to order more CTs, order more consults compared to physicians who are not burnt out. There's also studies that show that burnout is associated with less patient satisfaction and adherence. So when you discharge your patients, they're much less likely to do what you tell them to do. They're not gonna take the antibiotics, they're not gonna do whatever it is because they can tell that you're burnt out and they're probably not gonna follow your recommendations. And finally, we know from lots and lots of studies that burnout increases medical errors and then also is associated with lower quality of care. The majority of these studies are self-reported, but there was one study that came out a couple of years ago out of Switzerland that was actually really compelling. They looked at units in ICU in Switzerland of physicians and RN teams, and teams with higher burnout had actually higher mortality ratios on their units compared to units with less burnout. So that was one of the rare studies that actually looked at concrete, objective patient outcomes, and burnout was associated with worse outcomes. But the more sort of potentially compelling case for why we should care about burnout is the business case. So I highly recommend you guys taking a look at this article when you have a chance. This came out a couple of years ago. It was a really landmark article written by Tay Shanafeld and Christine Sinsky. And this article was really geared towards CEOs, CMOs, and it laid out a very clear financial case for why you should invest in burnout. And the premise for why there's a business case for burnout really lies in attrition. So there have been a lot of studies out of Stanford in the last couple of years that looked at burnout amongst physicians and their faculty, and they found that people who were more burnt out, academic physicians who were more burnt out, were much more likely to reduce their FTE over the next 2 years, and they were also twice as likely to actually quit completely and go elsewhere. And they found that this was actually a dose-response relationship, meaning the higher your burnout, the more likely you're to reduce your FTE, and the more likely you are to quit. So the business case for burnout is fourfold. One, it's really, really expensive to replace a physician. Most estimates say that to replace a faculty member at an academic institution, it costs about 2 to 3 times that person's annual salary for onboarding, all the other associated costs. So it's very expensive to do it. 2, turnover, in turn, increases burnout in colleagues who remain. So there's low morale in your group. People who leave tend to cause burnout to increase in the rest of your team. 3, there's also tend to be disruptions in patient care. So maybe in emergency medicine, it's much more sort of scheduling issues, on-call issues, but from an inpatient standpoint, you can imagine if an oncologist leaves, a surgeon leaves, all those outpatient people need to find a new doctor, a new primary care doctor, et cetera. So it's quite disruptive to patient care. And last, the fourth case is that when you lose mid-career senior staff, you have a brain drain in your institution, and that's quite detrimental to productivity, mentorship, and leadership. So when these researchers looked at an actual dollar amount, they found that at a national level, it costs about $4 to $5 billion a year annually for burnout-related costs related to reductions in FTE and attrition. At an organizational level, they argued that it's about $7,600 per physician per year. And these are all rather conservative estimates because this is just burnout related to decrease in FTE and attrition. That is not even accounted for how burnout causes higher bounce backs, medical errors, quality of care. So these are sort of bare minimum costs that are likely associated with burnout. So I'll pause here to say there are lots of reasons to invest in burnout. There's the personal, there's the educational, there's the quality, and finally there's the business and the financial. So I'll pause here to have each of our panelists potentially spend 3 to 5 minutes to kind of just talk about why burnout matters to them in their department and what they do in their shops with regard to burnout.
Well, thank you for inviting me to this, and I'm happy to share my thoughts on this. I have been trying to improve wellness, I guess, for the last 8 to 10 years. And I've gotten a bit discouraged along the way because I noticed that wellness initiatives tend to reinforce the positive outlook of not burnout physicians and sometimes have a negative effect on the physicians that need the wellness the most. And this is what I call, or Dr. Jillian Horton wrote a great book called We Are All Perfectly Fine. Called Muffin Rage. And if you don't know what Muffin Rage is, we had a particular, my employer decided to send out tins of cookies at the same time they sent out massive undeliverable expectations to every physician. We all showed up in the ED the next day with our tins of cookies and just dumped them on the nurse's station and said, we don't want these friggin' cookies. And so you have to be very careful about wellness and doing tokenish things. If you look at the Maslach scale, there are 3 things that are really important. Emotional exhaustion, depersonalization, and that loss of accomplishment, personal accomplishment. The burnout scale is very big on emotional exhaustion. And those 3 fit into a general assessment that would best be called occupational depression. And occupational depression seems to be most related to unresolved stressors and unmet expectations, right? So you are an assistant professor, you've been toiling away, you've been overlooked for promotion. You go to put a splint on, there's no web roll in the supply cabinet. You're using the command phone and it doesn't work well, and so you've got one finger in your ear, you've got the phone. All these unresolved stress, unmet expectations are your action plan, action points as chairs and vice chairs. And so while originally my wellness concepts focused on, let's do activities and let's revitalize Journal Club and what have you, recently I've been very focused on knocking out these unresolved stressors. And in particular, working on unmet expectations. When I meet with individual faculty members, I try to find out what their expectations are and where they are not being met. And they're as variable as people are variable. So I would just throw that out as my little 2-minute brief on wellness, and encourage you to avoid just taking a toxic situation and adding cookies to it in your wellness programs, and really think about how, as leaders, you can begin to break through on the unresolved stressors that are really at the core of the problem.
Awesome. Thank you for that. I know that frustration of going somewhere, and I was at an institution once where when I just started, and I couldn't find for DKA the insulin drip, and I looked it up in like 57 different ways, and someone said, "Oh, it's under insulation drip," and I was like, "Oh, of course it is. Of course it is." So,
Throw your muffin against the wall.
Exactly. No, actually, I started beating my head up against the desk, at which time a medical student started saying, "Dr. Blomkamp, do you not like your job?" And so, anyway, but back to wellness. So, I think, wellness I'm at an institution where wellness is a real thing, and there's a CWO, and there's a lot being invested in wellness. So, I consider myself very, very lucky and very fortunate to be at such an institution. But I thought I'd mention a few things that I think have been really important that are not expensive and don't take, a gazillion resources. Because of course, if you have a ton of resources, you think you could create wellness, happiness out of anything, which I don't think is true, by the way, but nonetheless. The first thing is acknowledge that the conversation is real and that wellness and burnout exist. And unfortunately, there are always still going to be faculty in the room who still are sort of do the wellness and roll their eyes in the back of the head and say, what is this business about happiness? And when I was a resident and walked, uphill both ways, blah, blah, blah. And we just have to stop that. We just have to say, from a leadership perspective, we're talking about it. We're talking about it. And we're going to talk about ways to mitigate burnout, increase wellness, and that is an actual discussion item. It appears on the faculty meeting agenda or the retreat agenda or something. Someone's assigned to it. Someone's a wellness director or a vice chair, whatever that is. And don't hide it anymore. Don't try to say, oh, the wellness person or the wellness committee or something that makes it sound like it's not real. It's real. If anything, that time is over, and what this data shows is that it is very real. And there are 3 things in emergency medicine that as leaders, when you're talking to folks, that really, really matter and affect their wellness and burnout. And that is their schedule, clinical offload, and compensation. So over plan to communicate whenever those topics are going to be discussed, and really consider the wellness and burnout implications of anything around that topic. So one thing that we started in our department, and I owe it to my wellness director, L.A. Alvarez, who I'll shame here, he's right here, who he developed it. Raise your hand, L.A. There you are. He came to me and he said, I think, Andre, I think people need to talk about it. and when as faculty, there's always the undercurrent of chatter, like what's going on, who's mad about what, it's happening, I turn over, you know what's happening, it's a buzz. And the notion of, you can't really talk about it at faculty meeting because there's not enough time. And it doesn't seem like the right time. Let's make time to discuss the things that bother us. So once a month, we have a chunk of time where there's a pre-selected topic. And in this case, this was about, altering schedules. And we're gonna talk about that. And it's a safe space and people can say anything, and he leads the discussion, and my vice chair of academic affairs leads the discussion, Jody Vogel, and we talk about it and really talk about the issue and what's fair and what's not fair. And I'm there. I come sometimes late on purpose and try to address some of those things, but people really talk about it, even to the extent you pre-plan it such that your very worst, I don't want to say enemies, but you're not so fans. You say, I need you to talk about what you don't like about this. I really need you to talk about it. And somehow, we've been doing this now for close to a year, and having faculty have that space to talk about it, I mean, people come every month. It's totally optional. We don't take attendance. It's always, we've done Zoom and in person, and I think it's really helped. It's been a really, really great idea. So thank you, LA. It was a great thing. Steve.
Hi, everyone. It's really nice to see everyone in person. It's the first in-person meeting in 2.5 years, 3 years for SAEM. So my take, in addition to the nice introduction I had, so I am our system at UMass, our system CXO, which is Clinician Experience Officer. So I am the Chief Wellness Officer for our 5-hospital system, as well as my department. So some of what I'll talk about is related to that role. First, I think we need to acknowledge the effect of the pandemic has had on leaders. I don't think the worker bees, the people who are filling the shifts, necessarily understand that, but it has been horrible for everyone, including leaders. I think one of the overall themes for this is Leadership Development Forum, so leadership themes for addressing burnout, and that is promoting thriving and wellness, is empathic leadership. And there's really kind of 4 pillars, I think, to empathic leadership. The first is transparent communication. Andra said over-communicate. Again and again, I fall over that. And you think you've communicated incandescently obvious to everyone. And you're still missing a lot of people. So transparent communication. Another thing called humble inquiry. I think Andra also addressed that. Right, so asking for ideas, asking for solutions, be willing to be wrong. Professional development or facilitated professional development. So really taking on, and we're going to look at some of the data from the survey, the things that people in your department want to develop themselves. And it's going to be different from worker bees, right, who show up and do the clinical shifts, and the education people primarily in education, educators, and the clinical research and the basic research. So having a real professional development plan for all of them frequently. And then lastly, recognizing individuals and achievements and almost over-communicating those as well. Saying thank you goes a long way. Recognizing people for whatever it is that they accomplished or award they got goes a long way. So some of the things that we've done in at UMass and as a system CMO, but in the department, things that aren't addressed in the survey that are really important, and Andra, again, because she's brilliant, she brought up schedule, so sleep.
Oh, sorry.
She just hit me. So sleep has tremendous effects on people's wellness. That's been shown again and again. And so we just finished a clinical trial of a sleep system that thermoregulates and dehumidifies beds in order to get people to sleep more. Really the interesting, it does actually improve people's sleep a lot, but it doesn't, if you wear an actigraph on their wrist, it doesn't look like it changes anything, but everyone feels better. So recognizing that sleep is a big deal, and I'm trying to get sleep pods placed in the hospital as well, so people can take strategic naps, actually tactical naps. The other thing that it's not addressed here, is it here? Is the tremendous effect of abuse and mistreatment on everyone. There was just this week in JAMA Open Network an article published by Susanna Rowe from BMC. She was the lead author. And we've done this as well at UMass. So whether someone is a medical student or a full professor, those who have been subject to abuse and mistreatment have, it's hard to quantify, but much less professional fulfillment, much higher burnout. And the interesting thing is, so we surveyed our whole group about 18 months ago, and I was a little bit surprised. About 85% of abuse and mistreatment, maybe it won't surprise you, comes from patients and their family members. Very few anonymously reported come from chairs or program directors. And then there's, I think nurses were second, and then fellow residents or residents from another service. Actually, they may have been higher than nurses. So we are actively so the question is, how do you address abuse and mistreatment? So we have standards of respect. We have new patient and visitor guidelines that are going into effect. People are signing a thing saying they will abide by it. And if they don't abide by it, they're escorted off the premises. And on my other ID, my work ID, we created a QR code so that people can, in real time, report anonymously or not if they want abuse and mistreatment. Because if you try to quantify it right now, find me a study that they can quantify abuse and mistreatment. It doesn't exist. So we've tried to make this as easy as possible. QR codes on the back of your phone, on your ID, you take a picture of it with your, it's not technically a picture, but right with your phone takes you right to it. So we are trying to quantify that. The other thing that has been shown to be beneficial, and we've rolled out, my office sponsors this, is wellness coaching. And that gets to part of professional development and figuring out what does someone want, right? If someone is on the educator track and sees themselves an educator, but they're working 1,600 clinical hours and they're on the clinical shift, shift's open, someone has to take it, they get on that treadmill, right? It's really hard. So wellness coaching has been shown to be beneficial. We just finished a clinical trial of that. We're writing up the results. The answer is it works. And the last thing that I think is critical is minimizing and explaining change. So I'm a former I'm in recovery from being a program director for 9 years. And I did not appreciate the degree to which uncertainty and change really affects people. And if they're chairs, right? So they probably spend a lot of their time like recruiting, getting great people to come, right? And that's a lot of work, and it's hard, and it's costly, and it's also, when people leave, that's change, and that's really hard. So kind of communicating about that. I'm not a chair, so I don't have to do that, so I don't know how to do it. But change is really hard for people, especially those who are not at your level. And the last thing I wanted to talk about this has not been it's been quantified a little bit in medical students, and I think this plays a big part in people's burnout, lack of wellness. First of all, burnout and wellness are not the same thing, right? So you can be not burnout but not well. And my job is to help people thrive and be well. That's my goal in life. And I think for emergency medicine, one's ability to tolerate uncertainty and risk really has a big part of people's ability to work. So there are people who, as docs, can't tolerate uncertainty, right? Or they have zero tolerance of risk. So they pan scan everyone, right? And they're there 3 hours after the shift. That is not good for anyone, patients or the doc. And so I think part of the professional development conversation is, assessing people's ability to tolerate uncertainty and risk, and those who can't, put them in, allow them to transition and spend part of time in areas where that's less of an issue, urgent care or low acuity areas. I give away every shift when I get put in our fast track urgent care, low acuity place, because I can't stand it. I can't stand it. But there are some people, right, I can't stand it. But there are other people who like working there, right? So I'll take your weekend overnight shift if you please take my low acuity shift. And so figuring out with conversations what people want and allowing them to move to where they're more comfortable. Can I say one other thing? So the other thing that we're looking at is, so because I'm a systems CWO, I hear from everyone else, and electronic medical records, right, are an issue. I will tell you, we actually have it good compared to rheumatologists, oncologists, right, who spend all day in their inbox, all day with prior authorizations. We don't do any of that, thankfully. We do have our own challenges. And one thing that we are doing is a trial of AI to do our charts. So, and we're doing it across specialties. And so you will use your own phone and log in, and the phone and the AI will create a chart from your interaction. And unbelievably, the greatest resistance to this, they have to use their own phone. People want us, they don't want something on their phone that's going to listen to their conversation with people. So now we're having to, like, are we really going to buy people phones so that they can do this? Anyway, it's just kind of funny what people come up with. All right, those are all, my head has no more thoughts.
Okay. So we'll open it up to questions in a bit, but before we do that, I just want to show you guys some preliminary highlights of data. So we just published this maybe 1 or 2 months ago, so some of you may have already seen this, but if not, I'll show you the highlights of the data. So this was a study that we did. This was a cross-sectional online survey that happened at the end of 2019, early 2020, so pre-COVID, and we sent the survey out to all 3,000 faculty members of the SAEM. We looked at specifically 2 primary outcomes, professional fulfillment and burnout. And then we looked at those 2 outcomes in relation to their impressions of these 9 individual and workplace factors. So we asked them their impressions of their academic work environment, values alignment, control over schedule, EHR, meaningfulness, appreciation, compassion, and impact of work on health and personal relationships. And these are some of the highlight results. So 771 people out of the 3,000 or so responded, so a response rate of 25%. Some of you may be in this room. Thank you for doing that. Some basic demographic stuff. 57% of the respondents were male, 77 were white, and half of them were junior faculty, 28% were associate professors, and 24% were professors. In terms of our primary data, we found that about 40% reported professional fulfillment, and about the same also reported burnout. 27% reported neither fulfillment nor burnout, and about 6% reported both fulfillment and burnout. So I'll pause here to see if our panelists have impressions about these numbers, if they surprise them, and why or why not.
I don't find them surprising. It's a very difficult, it was a great paper, by the way, and a very difficult area to study. And I think when I reflect on times in my career where, I had the most emotional exhaustion, I probably would have just said, I'm not burnt out. So it's a difficult area to really grasp and to really, tease out. And so I think the data, you just need to reflect on whether the data really are true in that regard, and whether we all experience really are displaying some type of burnout, even though we say, well, I'm not burnt out.
This was the first survey of its kind that was specifically geared towards academic emergency medicine. So I think it's really important that we realize that that's what was honing this. We were using the Stanford Wellness Survey with academic questions added to it. So it was a validated survey, but with questions that were obviously not validated yet on top of the survey. So it's the first survey of its kind, but I think we have to view it within the context of academia, which I think is really important as we consider what this is within the context of emergency medicine. So I think, one, talking about the overall burnout, I think it's interesting to suggest that perhaps burnout in academic emergency medicine is not as high as regular emergency medicine, just as a potential topic to consider. And then I'm particularly interested in the ones who are neither professionally fulfilled nor burned out, or both, because I try to put myself, and I think maybe I'm in that 5.7%. I don't know, I can't decide, but those groups somehow fascinate me, and I think there's something to be learned by people who are in that 27.8% who just sort of plod through life and have no meaning and are not burned out, nor are they. I don't know. Those are the people somehow I want to help. But so I'm curious about that specific group. But overall, the data doesn't surprise me at all. But I'm somewhat reassured that academic emergency medicine and that I think that involvement in your career, other than just clocking in and clocking out, is helpful.
Yeah, I agree. I think because we surveyed academic physicians, the burnout is lower. There's one other part to it, though, I think is important. So the criteria here for burnout was high burnout. So if you see a Medscape survey or other survey that says 70% of emergency physicians are burned out, they are not differentiating, the degree of burnout. So they may be low burnout or medium burnout or high burnout. So it's a little bit of apples and oranges there. But I think we can agree that having a purpose of academic medicine does mitigate or prevent burnout to some degree.
And I'll just add that one of the points we made in this paper was that there's a difference between professional fulfillment and burnout, right? And one of the reasons why we chose the Stanford instrument to use is because it wasn't just measuring burnout. So the Maslach burnout inventory only specifically looks at burnout. And I would say maybe 10 years ago when we were talking burnout, it's all about mitigating burnout. How do we fix burnout? But this showed that just because you're not burned out doesn't mean that you're also professionally fulfilled. So we wanted to change the dialogue to, yes, you want to address burnout, but then how do you get people to also be professionally fulfilled at the same time? So we looked at these outcomes by gender, race, and rank, and interestingly, we found that in terms of professional fulfillment, men were statistically more likely to report professional fulfillment than women. We did not find a statistical significance with regard to burnout and gender, and we didn't find any by race and ethnicity. So I'll pause here to see if people have any comments on that.
So the most interesting thing here was the no difference between high burnout in men and women. This was pre-pandemic. We surveyed during the pandemic, and our mid-career female faculty had much worse scores. They looked like everyone who had been subject to abuse and mistreatment. Honestly, they weren't much different. We all know why that is. So I think it's interesting here that maybe in academics, when we're not in a pandemic, there probably is no real gender difference in high burnout.
I was surprised by this data. I wasn't expecting it at all. In some ways, I was reassured in that I feel as though emergency medicine as a whole was perhaps one of the first specialties to really pay attention to issues of gender and race equity more in a meaningful fashion, more so perhaps in other specialties. And I prefer to remain optimistic in my interpretation of that data.
Yeah, this is a great example of the unmet expectation and unresolved stressors that each of your faculty are dealing with. And this is where DEI initiatives and wellness and burnout come together. And as leaders, you need to really focus specifically on each individual faculty member and identify what their needs are and how you can help, resolve the unmet expectation or resolve the stress. It could be the schedule. There are particulars about the schedule for one person that fits well and then fits poorly for another. And I think what you're seeing here is where, what we know about the DEI workplace and burnout, where they come together. And it's a call to action for chairs and vice chairs.
I do think the data would be different, though, now. I do think we'd see some differences now between groups.
So we also looked at this by rank, and maybe not surprisingly, junior faculty were much less likely to report professional fulfillment than senior faculty, and junior faculty were much more likely to report burnout than associate professors and full professors. I'll pause here again to get opinions on this.
Again, so you're a professor. You've managed to, navigate that system in some way, shape, or form. You're more likely to have some of your expectations of career met by the organization. You're, an assistant professor, and you are facing obstacles, you, again, are having expectations that are not being met. And so, that deciphering that for your department, your group, and each individual, I think is really the key. And when you are gearing your wellness initiatives as a concept, you're focusing on where you think you're going to discover the most distress. And you might as well start with the junior faculty.
So I made a real took a real risk with my department based on this data, and decided to kind of flip the schedule or flip clinical offload and give a lot more clinical offload to junior faculty and direct them towards resources and give them resources towards training opportunities, career development, more guidance as to what they should be doing with that time, because it makes so much sense, right? When you're junior faculty, you're trying to get your feet wet, you're probably getting married, raising a young family, you're working the most clinically. It's like, duh, no wonder you're not going to be professionally filled and burned out. So, but that also meant increasing the clinical load of more senior faculty, and people were doing so. So I created a few fans, and then I created a bunch of enemies, and I'll let you know in 5 years if it worked. I don't know, but it just seemed like we had to do something for our junior faculty to give them a chance. So it wasn't just the few who could stick it out or had a supportive spouse at home or something that would actually give people a chance to be able to do it. So I poured on a bunch of fertilizer, and now I'm going to sit back and see what happens.
Thank you. I think those are all both great points. I think the other part of the slightly under-recognized answer to some of this is what in epidemiologic they would call the healthy worker effect. Right. So by the time, if you're a full professor, you're still in academic medicine as a full professor because you are fulfilled, and you're probably less burnt out than someone who flamed out and left medicine altogether, or God forbid went to urgent care or something like that before they reached a full professor.
So we also looked at a couple of these primary outcomes and did adjusted odds ratios of all the factors that we asked about. So remember those 9 things of personal and workplace factors? And I highlighted with these arrows the 3 things that we found to be most associated with professional fulfillment. So the highest was meaningfulness of clinical work, followed by perceived appreciation, and then the impressions of their academic work environment. I personally was very surprised by this data. I did not think that things like meaningfulness and appreciation would be the highest, but I wanted to get your guys' thoughts.
Yeah, that fits perfectly with my experience. So it may be, your junior faculty may say, I expected to work a lot of hours, right? I expected that. But I expected to have opportunities to improve my mastery of my research initiatives or what have you. And so that connectivity is what I see in that survey. When those 2 things match up, you have a department, and you may have experienced this, where you'll work in a department, and there are so many challenges, but people are happy. And it's because everyone feels like there's an alignment of their expectation, the mission, the purpose of the department. And then you've worked in other areas where you have unlimited resources and people are miserable, and that's because you have that misalignment. So I think that's what I see in those domains.
And what's interesting, I just want to highlight, because so much of the conversation is about EHR and fixing the schedule, whereas it seems like this seems to be meaningfulness and appreciation seems to play more of a role, potentially.
I'll second that about the clinical environment, because I think that's where we do have some natural misalignment between, for education and research and things, we sort of have some control of that within our own departments, but in the hospital we have, nursing and techs and radiology and other services, and, boarding is like, the colossal beast against, everyone else in the world. And so that part just seems, to me, it seems like the part where alignment is not good, and we just have this sort of learned helplessness.
Yeah, when I saw these 2 quick stories that I think kind of highlight this, and I can't overestimate what I think that empathic leadership, the benefits, and when you have the lack of that, the impact on faculty. So in my role, I meet with every chair twice a week. And when I was meeting with one chair to talk about his department, he said, "Well, I don't know that we need you. I meet with every faculty member every 3 months. I go over all their RVUs. I go all of their billing. I go over all of how long it takes each patient to see them. I show them how many patients per day they see, right, on and on." I'm like, wow, like he thinks that's what leadership is. And I suppose, for maximizing RVUs in his department, it is. And the other, so I'm going to meet with an entire department, and I'm new in this role as the system chief wellness officer. And I walk in, and they're in this big auditorium with the whole department, and the chair says, "Here's Steve Bird. You probably all know him from the emergency room. He's now the system chief wellness officer. And just so you know, I didn't approve his position, but he's going to here to talk to you about what he's going to do." So that's what I'm up against at a system level. And, so I think, poor professional or low professional fulfillment, and as the next slide we'll see is increasing burnout, the impact of leadership like that, it's kind of hard to overstate.
I will just tell you one story. So I was junior faculty at Bellevue. I did the overnight shift. I was signing out to Dr. Goldfrank, who came on. And when he came on, I immediately started bitching about X-ray and patient transport and why I was slowing everything down. And Dr. Goldfrank said, "Richard, that is why you're here." So I thought, oh, my meaningfulness just got flipped. It is my job to take all these patients to X-ray and make a difference. And it had a big impact on me. And I think that as leaders, if we bring purpose to something that seems trivial, like, yes, that's one of our problems. We're overcoming that. Appreciate your help on all of that. Give me some insights and tell me how we can do better. That's for real. I mean, that really does flip your perception of the workplace.
Yeah, so this last slide I want to show in terms of the data is that we found that people who reported low meaningfulness of clinical work, low self-compassion, and worse impact on relationships were more likely to report burnout than all the other factors. So not EHR, not control over schedule, it was those three things. And they kind of mirror what we saw earlier, meaningfulness, appreciation. Again, that surprised me. I would have thought it was scheduling, EHR, where all the attention is. Final thoughts?
I think we need to see that in academic emergency medicine, that maybe we're not, what this is telling me is maybe we're not spending quite as much attention talking about how really what we're doing is trying to improve clinical care and focus on everything we're doing in education and everything we're doing in research ultimately is to improve the care of patients. And the folks who are, slogging in the pit and whatever you want to call it, the folks who are working the most clinically and the junior faculty and so forth, they're doing a really, really important job, and they're carrying forth all these things that are being brought to bear by everything else we do. So this was a message for me for the whole of academic emergency medicine, is that we can't be so gung-ho to be doing research education. That's important for academics, but let's not forget what the purpose of all that activity is.
Yeah, I was in Washington last week, and we were, advocating to push back on these Medicare cuts. And I spoke with a number of Congress staffers, and I said, look, emergency medicine is the face of the cuts that you are considering. Right? I have to go in the room with the patient. CMS and Medicare are some abstract concept, but the fact that the fees and reimbursement for emergency care is so poor in this country creates this environment we all work in. Not enough staff, not enough nurses, not enough resources. And so I think you have to acknowledge that, but then as leaders, bring purpose to it, meaningfulness to it, and saying, we're here for the patients. We're here to improve the clinical care despite the circumstances we're presented with.
So we only have 20 minutes left. I'm going to do a Q&A with you guys, and feel free to, if you have any questions, to just raise your hand and I'll call on you. But otherwise, we'll go ahead with some of these questions. But again, feel free to just chime in and jump in. All right, so first question for you guys is, how do I know if people in my department even want to focus on wellness? So if you don't already have a wellness committee,
Well,
if
are
you
there
don't have...
muffin stains on the wall from people throwing them?
Yeah, I know.
Yeah, so I think that it's a given that folks want to have a well workplace. But what I think the better question is that what form of wellness do people want to embrace? And like I said, in the beginning, I had top-down kind of wellness, but my approach now is to sort of block and tackle on stressors and allow wellness initiatives to come up from the group. And so as chairs, like, don't ignore the request for a few dollars for an outing or what have you, rather than saying, as we used to say in the Navy, Friday we're all going to have mandatory fun. Show up at this time. At the end, you will be happier. I guarantee it.
Yes, exactly. Well, I think here we're sort of preaching to the choir. I mean, wellness is a part of our jobs and is part of the basic tenets of our department, and it's part of it. So it's just a part of the culture, and you weave it in. And I'm sorry to hear that Steve has to exist in an institutional culture where there are still people like that, but I'm very fortunate to be at a place where it's an open conversation with everybody who's at the highest levels of the hospital and every chair and everything else, and it's just an accepted part of life.
Should I have a chief wellness officer in my department if one doesn't exist already?
It's a rhetorical question. I mean, I think at this point, I don't know how you couldn't unless everyone said, we don't want that, which I don't know why that would happen. But I think, the next questions we'll probably get to, though, what do you do with that, right? If you just, you give someone $100 a year to buy greasy pizza, right, that's not going to do it.
Mm-hmm.
Yeah, I'm not so sure if we need a chief wellness officer, but you need a departmental initiative around it. Mm-hmm. And I don't know necessarily whether chief wellness officer might end up putting lip service on a bad effort. So I agree with Steve. There's got to be some meaning behind the whole thing.
Yeah, I think that person, if it's a person, a single individual, it has to be clear what that person is responsible for and what they're doing. Otherwise, it's just another title that could be potentially meaningless. It could be done by committee, but the same thing can happen with a committee, like death by committee. Or it can be part of a departmental initiative, much the same way clinical care education and research is. But there has to be meaning behind it. I think there have to be metrics reported, just like you do for everything else. So some emphasis, and each institution kind of has its own structure around titles and things, and you have to adapt to whatever your normal structure is within. So in ours, every department has a wellness director. So, and that's what we have.
Dave's next study will be burnout amongst chief wellness officers.
That's right.
So what I'm trying to do at UMass is to get the executive leadership, so the CEO, hospital president, and each department chair to fund their chief wellness officer in each department, and fund to, I'm trying to start at a 0.05 FTE. It's not nothing. It's something.
That just passed right there. That was the 0.05.
I was about to say,
5 minutes you were speaking.
Yeah.
Well, it's something, right? When a
it's
neurosurgeon
really
makes $1 million a year, right, you're asking for $50,000.
Right.
So my start is at 0.05, and my goal is to get up to a 0.2 for every department to have someone.
Wow.
Easier to do in a bigger organization. I'm not there yet.
Yeah, that was going to be my next question. If you were to have a committee in your department or a wellness champion or a leader, do you put money behind it? Do you fund it with an FTE? So Steve, you were mentioning, what about you guys, Rich and
Well,
Andrea?
so the organization has all sorts of wellness things that have become the distracting wellness initiative. And so everything from, employee assistance stuff and, support for activities and gym memberships and what have you. And they've fallen into the background noise and don't specifically, I think, address the department needs. So I do agree with that notion that you've got to sort of focus it on the departments. The wellness problems in emergency medicine are different than rheumatology, as Dr. Bird will, I'm sure, point out. So you need to focus it specific, but again, my disappointment is a lot of bigger wellness initiatives seem to make, the people that go to the gym are happy to get the gym discount, and the people that are really burnt out and depressed are not going to the gym. And how to reach that group is the real issue.
I'll say that there's a spectrum of things that can address wellness for you, your faculty, and residents that can be everything from zero cost to things that are incredibly high cost. However, in regard to this, I do think that a meaningful and participating in somebody who is doing their job as a wellness director does need time, because it's a real thing. It's a real job, and it's a difficult job.
Yeah.
So within Michigan Medicine, our entity, we found it helpful in that those departments so when we started, we encouraged the departments to all have whatever they wanted to call it. It could be wellness officer, but just a lead person, because our overall entity really wanted to connect in and realize that everything that was going to happen to benefit people was probably going to be at the departmental level.
Right.
And so all the departments were encouraged to create the position and put a little bit of time with it. Some had more than others. But what happened also was the departments that were always kind of, dismissing it, there was some peer pressure to get them to actually name someone, and then it got that person into the larger institutional realm of wellness. So I think there is some rationale for naming someone, unless with it having a meaningful job description, position description, and some effort behind it. I think it helps them get in the mix of what's going on, helps them learn about the realm as well.
So what about for programs or departments who don't already do this? Should I formally assess for wellness and burnout, whether it's the MBI, the Stanford Professional Fulfillment Index, the Copenhagen Burnout Inventory, whatever it is? Should they formally assess and measure burnout in their department?
I think this is like step one. If you don't measure it, you can't change it. The big risk of this, and as Dave said, there are a number. There's the well-being index from Mayo, which costs money and is not great, right? There's all sorts of ways to measure it. Some validate, some not. The biggest risk is measuring it and then not doing a damn thing about it, right? So measuring it, poring over the data, communicate about what you find, and then the other saying is, if you're focused on everything, you're not focusing on anything. So find 1, 2, or 3 things that will be your focus out of all the results from the wellness survey, and then communicate and back the people to do it, and then measure again. And just so you know, so we measure every 2 years at UMass.
So I think I agree with Steve. Measurement is critical, and but don't be afraid of the results. So I will say that I am proud to say that Stanford Emergency Medicine is the least well department of all the clinical departments at Stanford right now. It actually is. It is the least well. Now, the good thing about that is we're very serious about addressing it. And also they throw some additional resources your way. But now we just did the survey again. We'll see how far we are from that again. But you have to own it, right? You have to get that data and not go, oh man, that must be wrong. You have to own it and say, you know, okay, we've got to do something about it.
Yeah, I think, and I would add informally to that, formally and informally assess the wellness and burnout in your department.
So we kind of touched on this a little bit in terms of the FTE talk. So not everything costs money to implement in terms of a wellness intervention, but should I budget for wellness initiatives more than just $100 for pizza here and there or whatnot? Should there be something more robust?
Yeah, I think you absolutely have to have that baked into your budget every year, and it does inform the organization from the bottom up. If you are presenting to the dean or others, here's the allocation of dollars that I believe is going to improve the wellness for the department, you should absolutely be doing that.
Our dean actually mandates it, that a certain percentage of our department's expenses go to wellness.
And I think Dave pointed out, I mean, the business case is, right, it's $7,600 per person per year in your organization is what turnover due to burnout only costs. Stanford in 2021 released a study that in 2 years, the estimated cost of burnout at Stanford, turnover just due to burnout was 15 to 54 million bucks, right? So if you can prevent one person from leaving, right, you've paid for most of the wellness initiatives, probably for your whole institution. It's that significant. And you, I'm looking at the next question, but so one of the issues with wellness, so wellness started in industry, right? So it's not like to keep your people thriving and feeling awesome about their job. It was to prevent them from having MIs on the job, because that's really costly too for a business, right? So most early, so predate maybe before 5 years ago, was managing cholesterol, blood pressure, all that stuff, right? But that's not really what we're talking about, in part because physicians overall are amongst the most well people in our society, physically.
So Steve kind of touched on this. How do I work on wellness in an institution with resistant leadership? People who roll their eyes when you mention wellness, talk about wellness in hushed tones.
Yeah, that doesn't happen so much anymore. But what ends up happening is, the proverbial shit sandwich, which is like in between two slices of wellness is a whole bunch of hell that that leadership asks you to do. And I do think it is our job to push back on that. I can tell you for just a recent example that we had massive push on the patient experience scores in our institution. All the while, boarding is getting worse. Folks were, resources were dropping. And, just as a department chair, I said, no, we're just not going to work on that. You can set that aside. There's no way that you're going to get an improved patient experience if operationally the place is a hot mess. And so I think that's the more likely, not so much everyone say, oh, yeah, we really support wellness, but meanwhile, do all this and do all that. So I think that's the real challenge, is how do you push back on something that is going to worsen wellness, and you already know it.
So how do I align wellness with other priorities in my department? And I think Richie just commented on that a little bit, but I don't know if Steve or Andra want to comment on this.
Well, I think the goal for, a professional fulfillment, first of all, I think the shift of the discussion away from burnout towards wellness and professional fulfillment is a really good one, because I think activities and the discussion around promoting professional fulfillment is when you can really get into, and what are the types of discussions and things that will promote professional fulfillment in all those key areas of academic medicine, research, education, clinical care, leadership. And weave it into the culture, becomes part of the conversation, and then it's not so strange when people talk about it and they don't talk about it in hushed tones and that sort of thing. But I think just weaving the concept of trying to drive professional fulfillment into the culture is one of the most valuable things you can do.
how do I prevent a wellness initiative from backfiring? So I think Rich mentioned muffin rage.
Yeah, it's really has to be done within all of these efforts are done in a certain context. Your faculty, your staff, your nurses, the techs, everybody lives that context. If a wellness initiative comes across as out of context, then it's just going to completely backfire. And you need to be aware of that.
We should all strive for failure, right? If you're not failing, you're not trying. So failure is okay, and you learn from it, move on. I think this comes to leadership again, right? With empathic leadership. So our CEO at UMass is an emergency physician. He was actually my mentor when I was a resident and junior faculty. And so during the pandemic, so he still works 1 day a month in the ER. He usually works with me, so I can prevent him from doing anything dumb. But so instead of working in the ER, our CEO would take a resident and work in our COVID testing tent outside the ER. And once a vaccine was built, he and his wife worked in our vaccine administration tent, right? So that's leadership. And so when he would bring some things, cookies, pizza, leftovers from a meeting or whatever, like people didn't view it as and he has candy bars that he gives out with his name signed on them. They're dark chocolate, which I don't love. But like people don't roll their eyes and throw them against the wall, right? It's like this guy who walks the walk, right? He's out there in the testing tent and he's bringing me, chocolate bars. I'll take the chocolate bar, right? No one felt there was no muffin rage at all.
As sad as the muffin rage story is, I don't think that should stop sort of gestures of kindness, small gestures of kindness, and they matter, and I think they do help, pick people up, and whether they're small notes or things or food or whatever, recognition or something, I do think those small things, no matter how cheesy they are, and maybe sometimes they backfire and someone dumps muffins in your lap, fine, but I think they have their place.
It's all about context and leadership, right? So, all right, so we just have a couple of minutes. So how do you help faculty who are showing signs of burnout?
Well, I do think that there is, you have to focus on the professional components of that. Burnout, again, is in symptoms of burnout are on a spectrum of depressive symptoms in general. And really need to keep your conversations focused on the professional environment, what have you. Many faculty who are struggling are dealing with a lot of stressors, personal stressors and what have you. And gently guiding them into, employee assistance and other things so that can be helpful to them. But focus, I think, your efforts on the exacerbating things in the workplace.
So I've adopted this notion that I don't want people to be numbers on a spreadsheet or have numbers after them. So while we say you should come to roughly X percentage of faculty meetings or conference or so forth, accepting the notion that people are going to have a bad quarter, a bad maybe even year. We've all had those, right? We all have something happen in our lives, or you don't get several grants in a row, or something happens where you just can't be as engaged, or you're more burned out, or something, and normalizing that's okay. If you kind of half check out for a while, that's all right, and you're not going to get in trouble, and you're not going to miss out on your whatever compensation or your bonus or something, whatever that's going to happen. It's okay to check out a little bit, and then also support whatever they're necessarily going through. And just let them know if that's the case. And also if that means changing jobs or changing locations or changing things, that's all right. It's okay to talk about it. And I think normalization of the tough conversation, I think, is one of those helpful things.
Yeah, this is the most fulfilling part of my job, is helping these people. And I think it's important to realize that for every person who's identified as showing signs of burnout, guess what? There are 10 other people who are burnt out and are just pretty good at hiding it. And so So the 10 that are good at hiding it are actually much more difficult, I think. So, what's been shown. So I get emails like this, I don't know, every 2, 3, 4 weeks from around our system. And so what I do is I reach out to them. I heard, and maybe there was a poor patient outcome or something happened on the ward, right? So I have a reason that I'm reaching out to them. And then what I do is get them into coaching. And it's not executive coaching, it's not professional development coaching, it's wellness coaching. And really one of the premises of wellness coaching, so one published study on this, and we're writing up another, is giving people the agency to figure out what the hell they want. And virtually all the time, people who are really burnt out, like crispy, they are not doing things that they want to do. Right? What they envision themselves doing with their life and their career is wholly opposite of what they're actually doing. So until they recognize that, they may not even recognize it, but until they recognize it, nothing's going to change. So what doesn't help is take a week off. Right? That's not the answer, because of whatever the environment is, their environment they've been dealing with isn't going to change. So they just come back after a week, and within 5 minutes, they're back to the same mental state they were before. I won't pretend that what I do is right. I have all the answers. It's just the way I think that I think that's the most important thing that I can do, is help them figure out what they want, and then help them develop the agency to make the changes that they want to do and haven't had the ability or courage or self-awareness to do. Dr. Wolf.
Yeah, it's transitioning. So let me add one thing, because I agree with what you said, but I think the very first move on your chessboard, the starting point, is the tough one. I usually sing to them, "You've got a friend in me." In other words, make them know that there's somebody listening. Make them know that there's somebody that actually hears it, believes it, is going to help them navigate. And then secondly, when you've seen one case of burnout, you've got to basically take it apart and figure out what are the drivers, so you can tailor the way to help that person. And sometimes it might be a different tone, but a lot of times it could just be shuffling them around, finding things that are just going to get that mojo back.
So in the last 2 minutes, I want to ask our faculty, our panelists, what does work-life balance look like for you and your faculty?
Real quick personal story. So I've been like the worst case of burnout in history, probably. As part of my professional development, I had a coach, and she was awesome. She did 360 evals of a bunch of people and wrote up this report. And the first 3 sentences of the report about me were quotes from people I work with were, "Steve looks terrible. Steve looks like he's carrying the burdens of the department on his shoulders, and I'm worried about Steve." So that was the wake-up call that I needed to unscrew the things that I was doing. And largely, the immediate thing was I just started saying no. I'm not doing that, I'm not doing that, I'm not doing that, I'm not doing that. And then figure out what it is that I wanted to do. And actually, I created the chief wellness officer role for our system and presented it to our leadership, and they said no. And then 2 years later, they came back and gave me 4 times the money that I asked for in the role.
That's awesome. I cringed at the question because as Rich said, when you see one example, you see one example. So I think it looks very, very different for each faculty member. And I feel like you sort of have to just provide resources and troughs of ability for people to access resources, conversations, discussions, and people access different things in different ways so that they can take and pick from that. And some people are not going to go talk to anybody ever, 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 ever. And some people will really use that resource. So I think it's tailoring or having a diversity of resources and things that people can take towards their professional fulfillment and wellness in a way that is broadly structured to meet the needs of your entire faculty.
Yeah, so for me, work-life balance, and I always feel like balance is the wrong word. Work-life integration is the word that I often reach for, and I like to it works out well when I have a work life complete with a work family, and we cook turkeys on Thanksgiving when we work together, and a home life complete with my family and all the things that we do, and those two things are both enjoyable and fun for me. So that's the integration I think we're trying to achieve, and I encourage others to achieve and try to help them get there.
Great. So I think we're out of time, but thank you all again for listening. I'll be around if you have any questions. Our panelists will be too, and I want to thank again our panelists for saying yes to this and for sharing all of their insights, because I always learn so much listening to you guys. So thank you.
Thanks, everyone.